low to intermediate risk where often the cure of the disease happens in the office of the primary care physician or the dermatologist. The other end of the spectrum, which is what Dr. Taube will talk about, is the distant metastatic disease spectrum, where it's spread to places that we don't think surgically we can cure the patient. And all of the systemic treatments, 7 new treatments that you'll hear about in the next talk, all come to bear. But the area that we've really focused upon for the last 30 years here is the intermediate and high-risk melanoma, a patient who, and I won't repeat all of the elegant and very succinct things that Dr. Holtzman presented to you, but a patient who has had an operation, has either a deep primary tumor, so an increased risk even after surgery, or has spread a microscopic, a single cell sometimes, to the regional lymph node, where even after surgery, we realize there may be a 30 to 40% chance that the disease would come back if we did nothing more, or when the disease is bulky in the regional node, what we call stage 3B in the algorithm that Dr. Holtzman presented to you. And we know those patients have a 60, 70, even 80% chance of relapse if we did nothing more than the surgery. So this is the area of adjuvant therapy, and where there are 9,000 or 10,000 patients, systemic disease, who have life-threatening melanoma from the get-go, metastatic, as we're talking about it from the beginning, and there are more than half of the patients we see who have this early surgically resectable disease where there is no other therapy needed. About a third of the patients that we see, 20, 30,000 patients a year in this country, who have disease which, if we operate it, we've done less than we would like to do if we don't add something beyond that. So when you think about the treatment options for metastatic melanoma that Dr. Taube will go through in much greater detail, as we face this disease, only 5 years ago, we only had 2 drugs, chemotherapy, dacarbazine, and immunotherapy called interleukin-2, which promotes the T cells to divide. That was it. And as you'll hear in the next talk, there are now many, many options and increasing options every year, including chemotherapy, which is now pushed aside a little bit by targeted therapy, which stops the tumor, the drivers of tumor, which differ for the tumor that begins in the gynecologic organs, the rectum, the sinuses, from the skin. Half of melanoma of the skin is driven by BRAF, so BRAF inhibitors were a huge advent. c-KIT, down here in the soft, whatever that is, orange, is an intervention with inhibitors that block the c-KIT gene, which is on in the mucosal melanomas a bit more than the skin melanomas. So different drivers, a different disease when it begins on your skin as opposed to in your sinuses, in the mucous membranes, or even in the subungual regions. So when we turn to adjuvant therapy, the challenge that we faced 30 years ago here, there was then no therapy. We actually brought to bear upon melanoma the first immunotherapy known as interferon alpha. So I'd like to tell you the story of how interferon alpha is a player in the adjuvant treatment, the post-surgical treatment of melanoma. A couple of years ago, we had its relative, a longer-acting form called pegylated interferon, but it isn't a different drug, and giving it in the way that the PEG was given may be a little less effective. So we have really 2 agents, 1 class, that are really active as we explored them as treatment for patients who had had a surgery. The disease was all gone, but we knew that the sword was hanging from a thread, and that in 30, 40, 50, 60, or even 75% of those patients, the treatment was not going to succeed with just surgery alone. So the premise, the underlying motivator for adjuvant therapy, is that our treatments must work qualitatively better when we give it after surgery than if we wait for the disease to come back and then treat. You know, for vaccination against tetanus, if you do it before you step on the nail, is a lot better than if you do it after you step on the nail. For immunotherapy, we've always believed that if you treat microscopic cells, a few cells, that haven't put the immune system to sleep, it will work much better. And we have laboratory data, but it's getting close to lunch, so I don't want to put you to sleep to talk about that. But the truth is, in people with advanced disease, as you will see in a minute, the immune system has been put to sleep by the very tumor that is metastatic recurrent tumor. And so that putting to sleep, that tolerizing of the immune system is what we hope to avoid by intervening, treating right after surgery when the disease is gone, at least the macroscopic disease is gone. So, what are the goals of our treatment? Well, I want to tell you all, and I'm sure I don't need to tell you, that our goal, and I think the only absolute motivation to do this, is if we cure patients. Survival has to be the goal, I submit, for adjuvant therapy. Who would do a treatment for a year, or 2, or 5, or more years, if you weren't doing it with the notion to cure the disease? But we have other endpoints, and since it takes sometimes 10 years to get to the endpoint, a significant change in survival with a treatment given today, for instance, after surgery done yesterday for a given patient, the hope is that we could find changes in relapse that would come years before mortality, and that we could make faster progress if we aimed at relapse-free survival, not just overall survival. And so in our most recent trials, we've actually said we're going to shoot for both preventing relapse, but also for preventing death. And these two, I submit, are the only valid goals, but there are other groups overseas in particular that have focused at what we call distant metastasis-free survival. That means a patient would be scored as relapse only if they had a relapse from a melanoma that began here, if that were in the lung or the liver or someplace distant. Quality of life has to be there, and increasingly we're looking at quality of life, but these are harder endpoints to reach, and I won't talk more about those now. So what do we know about the 30-year-old molecule called high-dose interferon that we cut our teeth on, so to speak, back in 1985 here in Pittsburgh? The trial that we wrote then, obviously written in 84, is called E1684, and this was the pivotal trial that led to approval of interferon given at high dosages for a year as adjuvant treatment of melanoma. No other treatment, no other combination ever tested in the interval since then has ever shown superiority to that benefit in terms of relapse-free and overall survival that we had in E1684. No new therapy, period, has shown an impact upon overall survival. And so we have done other kinds of analyses that, again, I won't put you to sleep at this later hour in the morning, but basically if you collect all 20 trials that have ever been done worldwide of the interferons, you grind them all up and spit out the data, they show consistent 18% reduction in relapse, 4, 5, 6% reduction in death. So even if you take low-dose trials for short intervals, longer trials of different forms like the PEG, altogether they show benefit, which is consistent as well. So these are the curves, but again, it's later in the morning, and this is the original 1684 trial where yellow was the treated group, blue was the untreated group. The differences in yellow, I want you to focus upon the number that we call the hazard ratio, 1.38. That means if a patient didn't get interferon, their chance of relapsing was about 38% higher than if you did get interferon. When we did the second trial, 24%. The third, the largest national trial ever done in the US, 33% higher. So there's a consistency here, isn't there? All of the trials show about the same impact, and only these two trials, 1684 and 1694, both showed significant survival improvements as well. So people said, maybe we don't need a whole year of treatment. Maybe 1 month is the kernel. And so trials done in Athens and in Oxford, Athens, Greece, obviously, and Oxford, the UK, tested 1 year versus 1 month. And the interesting thing is that even in a fairly small trial with fairly high-risk patients, the most recent of these, the Oxford trial, showed a significant survival difference in favor of the 1 year over the 1 month. So we think there is something to the 1 year, but we have pinned this down in a trial that's now actually being written up for press, a trial we call E1697, where we gave 1 month only versus no treatment in people who had lower stages of melanoma, stage 2A, a 20-30% risk, not 2B or 3, with a 40, 50, 60% risk. And in this trial, we had to stop the trial after about 4 years of follow-up because there was no difference between 1 month and nothing. But remember, it wasn't in the higher risk patients, and the data hasn't been all crunched yet, so we'll have this a little later. But the message is probably not to do 1 month of treatment, stop, because it doesn't look as though it's effective in the ECOG-led study 1697, and in 2 European and British trials, the 1 month favors, the 1 year is favored over the 1 month. So what about using a different form of interferon, the pegylated interferon that can be given only weekly? And that trial done in the European Organization for Research and Treatment of Cancer, which we can't say more than once, and we call therefore EORTC, tested 5 years of pegylated interferon, and when they first reported this, it actually had a significant reduction in relapse, but no impact on survival. And when they looked more at this, it looked as though it worked predominantly in the patients who had only microscopic disease, littler disease, not macroscopic, palpable, gross disease. And so if it works, it probably works in the lesser stages of disease, but that is the only other trial we have out there, and this is a summary that I think even as I boiled it down, is hard to read, but for the one column that I submit as the most important, overall survival, OS, the original trial has a benefit of, here it's portrayed as 0.67, that means 33% reduction in relapse. The follow-up on that was 0.82, so 18% reduction, I'm sorry, not relapse, this is survival, 18% reduction in mortality. The biggest trial we've ever done, the E1694, 0.72 means 28% reduction in deaths, and 0.76 means 24% reduction in deaths, as this trial was updated now a number of years ago. The EORTC trial, testing pegylated interferon, shows you what I mentioned already verbally, 0.98, which means 2% reduction in deaths, not significant, and 0.96 on follow-up. So, interferon we've had it many times, 20 to be specific. How can we predict the 1/3 of patients who do benefit? So there are 2 factors here. One is the tumor factors. The other are the host or immune factors. The tumor factors of interest are ulceration, what Dr. Holtzman mentioned to you as a prognostic factor, has been shown in multiple studies to be associated with the benefit of interferons. And so ulceration means a more aggressive tumor, but it means a higher chance of benefit from the interferon, and we don't yet understand how that's come. The second is that there is an interesting hypothesis that the more T cells, the more inflammatory infiltrate you have in a patient's tumor, and that was again on Dr. Holtzman's slide, tumor infiltrating lymphocytes, TILs, the more likely those patients are to benefit from that therapy. And this has been published from Italy, from the Mass General, and even from Pittsburgh, Drs. Rao, Dr. Mim, Dr. Gajewski. And so there is substance to the fact that if you've already started a battle, as you mentioned earlier, we can help the battle forward against the enemy, the tumor, more in people who've already got evidence of a battle going on. What about the host immune response on the other side? We've looked at this for many years, and what used to puzzle us, in fact, we'd sit in clinic and we'd see people come in who bleached out their skin. They'd lost their pigment in their normal skin on interferon. We scratched our heads. And then on interleukin-2, people would come in. Their skin had bleached out. So you ask, who's the cousin of the bad guy, the melanoma cell? It's a pigment cell in the skin, and we presume that starting the battle against the melanoma has had collateral damage against the normal pigment cells. So we've also looked in the serum, and it's way too long into the symposium to bore you with the specifics of this, but we've shown that the cytokines, the hormones of the immune system that are in the serum of our patients before we treat with interferon, predict who will benefit from our interferon therapy. So these are potential things for the future, but I thought I'd take you back 30 years. Mark Ernstoff, who now heads up the Cleveland Clinic Foundation, and I wrote a review in 1984. And we drew a picture. I'm sad to admit this is my artistry, but this is basically the immune cell, and this is the tumor cell here, and we hypothesized that our interferon might operate by 10 different mechanisms. Some of those mechanisms were to destroy the blood vessels. Others were to slow down the tumor cell by making its growth less rapid. Others were to go ahead and directly activate what we call lymphokine-activated killer cells, or ADCC, or natural killer cells. Again, a quick way to put you all to sleep. But what we didn't know about is whether the immune activation, turning on these lymphocytes, these fighter cells, these T cells, might be the mechanism. What we didn't even draw in this picture is the cell we call the dendritic cell, which is the teacher cell, the teacher of these T cells, these fighter cells. And so we then questioned over several years how to understand how this molecule reduces relapses by a third, reduces deaths by a quarter. And we said if we just treat patients before surgery, do a biopsy, say if a lymph node pops up, take a piece, then treat for a month, and then look at the surgical specimen of that lymph node to ask what went on that was associated with benefit. So we've now done this with interferon, with anti-CTLA-4, which you know as ipilimumab, and even with combinations. I'd like to walk you through this. Nobody has to take notes, but this is how we think we'll make faster progress, because here it takes 1 month to understand, does the agent work? Does it shrink the tumor because you didn't take it out yet? What happens in the tumor that is made to shrink by your treatment because it hasn't been operated yet? And we find that out by taking the tissue out, sectioning it, staining it, and asking what's going on. And that may lead us more efficiently to new trials, to the big trials that take 10 years from the time we start them to the time we actually get the results. So this is the schema for the original 008 trial, not 007. Basically, we took patients with bulky nodal disease. We call that stage 3B. We biopsied up front. We then treated for 1 month, 20 doses with interferon before the definitive surgery. And then we did the definitive surgery. Where was the answer? The answer was under the lamp. We looked under the lamp in the tumor, and we said before tumor treatment, how many T cells were there? CD3 is a marker of T cells. And even without pathology training, even without your statistician to help you, you can see there aren't many red T cells in this pre-interferon biopsy, are there? And here to the other side is the post-interferon biopsy. SCADs, that's not a scientific term, gobs of T cells that invaded that tumor over just the month of treatment. So I told you about dendritic cells, but their immunohistochemical handle is called CD11C. Before treatment, how many dendritic cells are there in this biopsy of a representative patient? Not many. After a month, 20 doses of treatment, just 4 weeks, SCADs, gobs. And so we've turned on the teacher cells, the dendritic cells. We've increased the numbers of T cells, the fighter cells. Why did this all happen? And so we said we got to look for the signaling molecules that drive the T cells that are part of the immune mechanism called STAT3, STAT1. And we stained for these signal transducer, transactivator molecules with a blue and a red stain for the nuclear and for the cytoplasmic part. And what you see is lots of blue and lots of red on the left in the bottom. This is just a routine tissue stain in the pathologist's office above. The tumor cells here are a little less happy after treatment, but you can't see that in any specific way that I can point to you. But how much STAT1 and STAT3, or in this particular case, it's STAT3 nuclear or STAT3 cytoplasmic, after treatment it's wiped out. And so STAT3 is the bad actor in the tumor before, which is eliminated by the interferon treatment, which we think allows the T cells into the tumor, allows the dendritic cells into the tumor, and accomplishes all of this remarkable effect that the interferons have. So those neoadjuvant studies done 20 years after the national phase 3 trials that proved the efficacy first taught us that interferon's working like a vaccine. It's working to induce an immune response to the tumor. It's knocking down the STAT3, it's increasing the STAT1, and it's driving T cells and dendritic cells into the tumor. We're looking at other things that I won't bore you with this morning, but this is just the beginning of the story. We have now other inhibitory receptors. These are inhibitory brakes, if you like, on the immune fighter cells that are trying to be mustered against the enemy in the body after melanoma develops. And one of them, we think in the central immune system, CTLA-4, another in the periphery, important PD-1, have been harnessed in the last several years. And so ipilimumab, the first to achieve regulatory approval, 2011, inhibits a central immune regulatory brake called CTLA-4. This efficacy shown in mice, shown better with mice treated with vaccines plus ipilimumab, or equivalent for the mouse, has been a signal that we may be able to someday use vaccines together with these new immunotherapies in treatment of melanoma. We've done a trial in the adjuvant arena, and this trial was ended 6 months ago, in fact, testing ipilimumab at a high dose and at a low dose versus our standard bearer high-dose interferon. We probably won't have data from this for yet another year, maybe 2, to say how much better, or maybe it is just the same as the interferon, or possibly would it be worse than the high-dose interferon, is this therapy. But the Europeans got a bit of a head start on us, began a trial where they treated patients with ipilimumab at only the high dose, 10 per kg, versus placebo. And they can do that there because they don't do much of the interferon treatment that we've been doing for 20 years here. But in this placebo trial, the toughest that you could possibly imagine, the most likely to bring forward a new agent, we now have some data, early data that was presented a few months ago at our ASCO meetings of last year. And what you see is a prolongation from 17 to 26 months, about 9 months prolongation of time to relapse, and early indications that relapses were prevented by about 25% using this ipilimumab given for 3 years at a dose that's higher than is approved in the US. So what are the downsides of that? Well, we can look at the different groups of patients who got treated, the patients who had microscopic disease that we know as 3A, bulky nodal disease 3B, even more extensive 3C. Odd thing we see here on what's called a forest plot, so everything to the left is an impact, an improvement, is that the 3A patients, the patients with the earliest, least disease, have what? The least benefit from this treatment. So the patients that we might have said as immunologists should benefit the most really didn't here. We don't really completely understand that. But patients who had bulky disease with 3B and 3C clearly had a 23-27% reduction in relapse. So then you say, what about survival? We don't have any data yet. Finally, you say, what about the downsides? What about the toxicities? And here there were 3 patients who died of colitis. These are patients operated for potentially curable disease who died of colitis from ipilimumab given as adjuvant post-surgical treatment. One died with myocarditis and inflammation of the ticker, and one with Guillain-Barré syndrome, a neurologic disorder that says that this immune therapy, which turns on many things, we hope anti-tumor effects, but sometimes anti-heart, anti-gut effects, has a potential double-edged sword that we have to consider. In some, a reduction of relapses by 25%, which was highly significant, no question about it. Impact greatest in the bulkier patients, but short follow-up, 2.7 years average. We waited 7 years for our first interferon trial. We think that maturity in this particular trial will not be reached until we get at least 5 to 7 years of follow-up, and zero survival data yet. Zero evidence whether it's preventing deaths in the overview, and significant toxicity. So we wanted to understand more about IPI. So what did we do? Well, you guessed it already. We did a neoadjuvant trial. We took patients who had bulky nodal disease, did a biopsy, treated for a couple of cycles, 6 weeks of treatment, and then did the full surgery, exactly like we did with the interferon. Here, we also did some PET CT scanning, looked at how much sugar was being burned before treatment, and here you see a lot being burned in these lymph nodes in the axilla, much less after 6 weeks. So an early signal of benefit, which is encouraging to us. We looked in the tumor tissue, before treatment, after treatment. You don't need your statistician, you don't even need a pathologist or me now. You can say lots more T cells in there. This is confirmatory of the hypothesis that we had with the other immunotherapies. The more T cells you have before, the more benefit you may get later. And also now, at 6 weeks of treatment, we can say that we're driving the fighter cells into the tumor with this therapy. What else can we say? Well, we'd like to avoid those toxic colitis deaths that happened. And they've happened all over the world, so it wasn't just the Europeans who experienced that. And what we found in a study of the cytokine, the immune hormone IL-17, is that all of these grade 3 and 4 toxicities were seen in patients who had high baseline IL-17 levels. So we have a marker in the blood of patients before we can test and see if they're likely to get colitis with this therapy. How to combine therapies for adjuvant treatment. Basically, we know the interferons work on the immune system, as we've exemplified here. Dendritic cells, T cells, are induced to go into the tumor. We know from anti-CTLA-4's effects in other studies that there are effects upon another cell that regulates the immune system called the myeloid-derived suppressor cell, the MDSC. So we said maybe these two immunotherapies work in non-overlapping fashion that will synergize with each other. Let's put them together. And so we did that in a trial that Dr. Tarhini has published. We saw a benefit in 26%, nearly additive benefit from the two of these things given together. Dramatic responses in ugly tumor that was caused to regress and stay regressed with the therapy using interferon plus ipilimumab. So we asked, how did autoimmunity correspond to that benefit? And what you see is that people who had autoimmunity, no or yes, had a significantly bigger fraction of patients who had either complete response, partial response, or stable disease, or benefit in some from this combined therapy. And what do you see in the skin of those patients? The same bleaching out, what we call leukoderma or vitiligo-like depigmentation that I mentioned happens with interleukin alone, with interferon alone, now with interferon plus anti-CTLA-4. So I'm going to skip over this, but to say we never believe when we do just one trial at one institution that anybody should take that as a take-home lesson. We said we've got to repeat this in the national cooperative groups. And since we've been the hub for the ECOG Melanoma Committee for the last 30 years here, we took this trial straight into ECOG, where 4 groups of patients were treated with IPI at 3, IPI at 10, or IPI plus interferon at 3, or IPI at 10 plus interferon, for what we call a 2x2 factorial trial. We want to find out, because that trial is still ongoing, how is this working? And basically, we've already got a trial in motion testing IPI plus interferon in the neoadjuvant setting. So I think you get the hint here how we approach things to find out quickly. Mechanism and benefit is likely to be in the neoadjuvant setting. The newest chapter in the immunotherapy of melanoma is anti-PD-1, program DEF1. We know that those tumor-infiltrating lymphocytes that go into the tumor early in the disease and later in the disease are poisoned by the tumor because the tumor makes a ligand, a key called PD-L1, that turns the switch on the T cell and kills it. So when anti-PD-1 came out and we knew that these T cells in tumor had lots of PD-1 on their surface, the tumor itself was making lots of the ligand PD-L1, and that these two things corresponded to one another, lo and behold, the treatment response in metastatic disease was a huge fractional response. 72% here, patients who benefited in some measure from this therapy. Objective responses in 30 to 40% of people treated with anti-PD-1, leading to the approval in September of last year of pembrolizumab and in December of nivolumab. These are durable responses. These are immunological responses to a single agent, anti-PD-1, that are durable. And so, needless to say, with these benefits, the next question is, how does this play in the adjuvant arena? So that trial has taken us a year to design, but it was finalized the week before last, is at the NCI for final approval now. We'll test pembrolizumab, as you see here, given for a year versus high-dose interferon. That's likely to be the study will be up over the summer. Durable responses with all of these immunotherapies suggest to us that this is really the basis for all of our future adjuvant therapies. Biomarkers, the ligand, this thing that the tumor makes to kill the T cells, guide us to who benefits from the anti-PD-1, combinations with anti-CTLA-4, anti-PD-1, anti-CTLA-4 interferon, and now here in Pittsburgh, anti-PD-1 plus the interferons, because the interferons turn on that ligand, which may make the anti-PD-1 more beneficial. I think with time, and so we're going to do a neoadjuvant trial. We actually have the first patient enrolled to this, testing pembrolizumab and interferon in the neoadjuvant setting. This is a drill that we will plan to continue, and I'm going to leave for Dr. Taubey to talk about the exploration of anti-BRAF approaches as adjuvant therapy, but say that the future of everything we're going to be doing is combinations. It's either immune plus immune therapy or immune plus molecular therapy, and we may even come back to test chemotherapy plus immunotherapy in the future. These are durable responses, and we think because in metastatic disease, durable response means likely this will play in the adjuvant arena. And immunotherapy, a discipline that didn't even exist as a modality for treatment of cancer 30 years ago, is now front and center in the adjuvant treatment of this disease. Thank you.